starting off with the problem that we're facing, underserved groups as defined by the U.S. Human and Health Services Department include U.S. minorities, such as African American and Hispanic populations, along with immigrants with limited English proficiency. And these groups do not access healthcare as often as they need to. And some of these reasons include barriers such as economic and transportation. For example, to see a primary care provider, it requires making an appointment, arranging for time off of work, or arranging for childcare, and then ensuring that you have transportation to the office. Additionally, patients aren't sure when their symptoms actually warrant a visit and when they should overcome those barriers. Additionally, this patient population has limited medical education, so they're not empowered to prioritize their health, and they also don't know how to navigate the healthcare system, whether or not they need to see different types of doctors or if they need a referral. Additionally, there's a lot of medical mistrust due to historical and their own mistreatment. In a genetic survey, 2/3 of Hispanic and African American populations reported that they distrust the medical system. And some of this mistreatment may be tied to the underrepresentation in clinical trials. Hispanic populations make up less than 10%, and African American populations make up less than 5%. And it's important to have representation in clinical trials so that researchers can understand the safety of a treatment and also how that will affect a diverse population. While this is a huge multifaceted problem, our recommendation to make progress towards this is Optum Rewards, an incentivized health data collection app that would increase the user's understanding of how their health is changing over time and what warrants a visit to the doctor's office. And also, Optum will be able to leverage this data on a population that they don't normally have data on to improve quality of care.
All right, so let's dive into what Optum Rewards will actually do. Patient will input their insurance information, and then they can either manually and regularly input their health data or automatically integrate the app with a third-party technology like Whoop or Apple Health. Once that's done, they'll get graphic representation of their health over time, and they'll be able to get ML-generated insights using Optum's vast medical experience. That's what this app is going to have that things like Whoop and Apple Health don't. We'll be able to, because of that medical experience and because we know their insurance information, we'll be able to provide suggestions to users like, it's been a year since your last checkup. Maybe you should see a physician. You're turning 50. It's time for certain other checkups. Or your heart rate, when doing your recent exercise, your heart rate was a lot lower than usual. It might be time to see a doctor. As the user engages with the app, they'll receive points that go towards health-focused rewards like discounts on fitness wearables and devices that could then further improve the value of Optum Rewards or other rewards that might be relevant to the consumer. Optum's also going to get a lot of benefits from this app. One big one is that Optum will be able to expand its data set on underserved populations to improve the value of the Optum Insight services. We think this is going to have a lot of positive knock-on effects throughout the medical industry as other health companies that are using those services can hopefully have a more diverse data set. Additionally, as Optum is able to train their ML models on this new data set, we believe there will be a lot of valuable health insights to be gained. Final benefit is that if a user who's using Optum Rewards has a lot of health data on that has been providing a lot of health data, perhaps goes to the doctor for the first time, now the doctor is going to have a breadth of really valuable information that they can use to provide better treatment to patients that maybe don't come into the doctor's office very often.
So tying this back to the 3 reasons we shared for why this group doesn't access healthcare as often as they need to, how Optum Rewards can help with barriers is that users can be more selective for when they actually need to see a doctor and when they need to overcome these barriers. Additionally, users will be able to choose whatever language they prefer on the app, and they'll even be connected to Optum providers that speak that language. As far as lack of medical education, through the app, users will understand how their health is changing over time, and when they see a physician, they'll better understand the recommendation that the physician is making. Additionally, because the app is recording their data over time, they won't have to advocate for themselves as much because that data is in the app. And finally, for mistrust of the medical system, all of the insights will be from ML that will be data-based and not done by a human. We'll have to ensure that the ML continues to stay unbiased. Additionally, over time, through interaction with the Optum app, users will build trust with Optum, and they'll receive rewards for the simple interactions that they have with the app. Additionally, they'll see that Optum only prioritizes their health because this service will be free. And finally, Optum will have data on these underserved groups that don't access healthcare as often, and they can use this data to improve health outcomes. So shifting gears to our customer persona, Meet Richard Smith. He's a 38-year-old man with 2 children. He and his wife work full-time in blue-collar jobs. They have Medi-Cal, and they rely solely on public transportation. A while back, he and his wife started using Optum Rewards because they were enticed by the discounts on health-related items, specifically the discounts on gym weights. Over time, Richard started noticing a rapid weight gain, and the app starts flagging him as a concern and assists him in making an appointment with an Optum provider. When he meets the Optum provider, he's actually diagnosed with hypothyroidism, a treatable condition, and he's able to get treatment immediately. Because of Optum Rewards, Richard saw a doctor a lot sooner than he normally would have, and this condition did not get worse.
All right, so I'll try and go through this briefly, but this is our implementation roadmap. If we were to start really soon, we can potentially start development in Q1 of 2023 and focus in on building up a team, narrowing the definition of the addressable audience. And then we can start really ramping up development through 2023 and 2024, aiming for a launch in Q1 of 2025. So we estimate that this app will take just over 2 years to build. And then I can call a little focus to our marketing campaign, which we aim to target low-income and underserved populations through using those strategies there. This was fun for me. My background was in software engineering, so I really enjoyed coming up with this part. The startup cost, we estimate that the app will cost about $11 million to develop over the course of 25 months. There'll be yearly fixed maintenance costs and enhancement costs of $4.35 million, mostly paying and continuing to support the development team and enhancing the features, removing bugs, that kind of thing. We foresee an average yearly profit of $11.74 per user. That's net of network and support costs, coming from increased patient engagement that we're able to drive through the app, as well as the additional value we're able to gain per user. We're able to give some of that back to our users in the form of the discounts that we mentioned earlier. We'd emphasize front-loading those discounts, front-loading those coupons so that when you immediately sign up or you immediately integrate your Apple Watch or similar device, that you're going to get more rewards for doing that than just the daily logging. If we were able to have an average user base of 3.3 million customers or users, we would break even in 2030 after 5 years of the app's life. And at that time, but we estimate we'll be able to do a lot better than that. An estimated yearly profit of about $16.5 million. There are some roadblocks that we've thought about. Low user engagement, obviously a risk, some botting, other things, but we do think there are strong solutions that can counter these risks. And we're also really excited how this app can grow over time. We mentioned that users would be able to input their own symptoms if they felt something could be problematic. And we want to be able to increase the power and the diversity of that type of verifiable data. And also, we think over time, we can continue to utilize this patient data in more and more powerful ways. Personally, anecdotally, I used to use a Whoop, and it knew that I was sick before I knew I was sick by like 12 hours. And we believe that there's a lot of power there to leverage for really improving health outcomes for everybody.
Kind of have this disconnect between how you started with the barriers and the rewards card. And how is this addressing barriers with a $10 per year incentive for all this data?
That's a great question. Do you want to start that one off, and then I can tell the story, or do you want me to?
You can go. Yeah.
Okay. There are a couple of different types of. There's a case that was really salient. My sort of ulterior motive with this one is the case of my grandmother was really prominent in my mind. So she passed away during COVID, and she had a cancer removed. And there was no follow-up done because of COVID. She thought she was really tough, and there were all these reasons why she didn't want to go to the doctor. One was the cost she didn't know. Another one is that she didn't drive. She would have had to take the bus, and it was really long. So we imagine that those barriers can be broken down. She did wear an Apple Watch every day. If the Apple Watch had said, "Hey, you went for your daily walk and your heart rate was a lot higher than it was yesterday. We've noticed these trends. We think you should go to the doctor." That would have been enough to bring her into the doctor for sure. I think that there are a lot of people that can go to the doctor, but barriers might be higher for other ones, and we want to lower those barriers.
How does your app collect the data?
So 2 ways. I think so. One is through manual entry. So a user can enter let's say that they're feeling a specific symptom that has them feeling nervous, then they would select, I'm coughing today. The app might not do anything with that information, or might just say that we expect you to get better, or just track it. Or if they enter something like I'm feeling chest pain, I'm feeling sharp pain in my side, that might cause the app to say, we recommend go to the doctor. The other way that would hopefully be preferable is an automatic integration with wearable devices or third-party health collecting devices like a Whoop, Apple Watch. Once you make that integration, the idea is that the app would be able to pull data from those devices and then share that with a provider and perform that.
So essentially a wellness checker. Have you looked out in the marketplace today to see if there are other wellness checker apps?
Yeah, I think so. I think there are a lot of competitors, if I understand your question correctly. I mentioned Whoop as one of that's a device that monitors a lot of information about your vitals, like blood oxygen and all this other stuff, in addition to steps and all that, and heart rate and everything. But it doesn't provide any it doesn't have any medical knowledge, which is what would set this apart. Most of these apps have stayed away from the medical space. I think there are obviously the HIPAA, there are challenges with that, that we think that Optum as a medical provider would be able to overcome. So to my knowledge, there are no widely used. I think if you think of Apple Watch as one of probably the most prominent, there's no, even though it monitors heart rate, and again, in the case of my grandmother, it monitors heart rate, it has the information, but doesn't have any knowledge, or has very little knowledge of what is actually matters for medical problems.
Well, I also meant there are actually apps that you can talk to, and it will walk you through questions of how you're feeling, and then go back and check against a database that does come from medical resources and data. So that's what I was referring to.
I think in our
these chatbot
Exactly.
solutions. Yeah. And there's a number of them out in the market.
Yeah, I think in our situation, this would be tied to Optum specifically. So we'd be connecting patients as soon as possible to Optum providers, especially in really urban areas like LA County that has 160 Optum offices. And so that's our goal through this app.
It said $10 per rewards per year. How much in your research do you need to give someone to not have decay in using an app?
It's a great question. I think that honestly, I think the $10 we imagine would be, like I mentioned, I think we should front load that. So when patients take the big initial steps, they're getting larger rewards. Hey, you synced your phone that's tracking your steps with the app. Here's sort of a $5 discount that you can use in our Optum store. Once that's done, then on a daily basis, hopefully without thinking about it, we'll continue to be able to get data, and then they'll occasionally get rewards. They'll sort of be reminders as they use it.
And hopefully they'll be enticed initially by the rewards, but through their trust with the Optum app and with Optum, they'd continue to use this. And we'd have to do research on study groups to see how long it would take for them to decay. And also, we were very conservative in our profits, and it may be that we're able to give more than $10 a year.
Some of my questions are also around your 2-year to develop and cost to develop. The $11 million seems a bit high in today, where there's a lot of open source capabilities that are out there that would probably accelerate your ability to create this app.
Yeah, and I think that's a good point. I think doing basic research of how quickly can you build an app, I think average costs range more from $50K to $200K. I imagine that when you're building something of, again, like HIPAA compliance, you're going to need legal advice, ML, building powerful ML models. Again, my background was I can just say from sort of anecdotal experience working on enterprise software where it was in a B2B setting and you really can't have any bugs, and there's a high need for very high quality software. I expect that it'll take longer. But again, these are conservative estimates.
Maybe just one question about, so you're making you know, a lot of your core premise here is around the connected wearables piece. When you think about the underserved population you're trying to address, have you done some research to figure out, I know you had on one of your early slides, you know, the percentage of low income people that have a smartphone, but like also how many of them have a Whoop or an Apple Watch or, you know, any of these other services?
It was a little difficult to find that specifically. And so that's why patients are able to manually enter their data. And ideally through the reward system, we're planning on giving discounts to wearable devices. And so hopefully over time they'd acquire those third-party devices, and that would be more verifiable data for us.
Another thing I would add to that, kind of looking forward, is that as wearables are becoming more and more, you know, the number of people that own these devices is growing pretty rapidly. And obviously, you know, 15 years ago, thinking that 76% of adults making under $30,000 in income would own a smartphone probably seemed pretty crazy. We imagine that that segment will continue to grow, and we'll be able to continue to penetrate it pretty deeply.
Hi, everyone. Thanks for being here today. My name is Helen Wick.
And my name is Maya. And today we are here on behalf of our Impact MBA team. Let me ask you this. Have you ever skipped a doctor's appointment because you were simply too busy with work or just didn't feel like driving another 20 minutes to a doctor's office after a long work day? Chances are you are not alone. Especially low-income communities face issues such as time constraints and money constraints to address critical health care concerns, potentially leading to long-term health implications. In the United States alone, about 30% of the workforce earn less than $15 an hour. Not even 1/3 of the low-income workers obtain health insurance through their employer. And Mississippi continues to score lowest on the health system performance score. So workers in Mississippi are earning way below what is needed to afford quality health care, including people like Lisa. Lisa is a 34-year-old Walmart employee living in Mississippi and working 2 part-time jobs. Her wage recently increased to $10 an hour, but does not provide her with health insurance coverage. Lisa was recently diagnosed with high blood sugar and a pre-diabetic stage, but she can't seek medical help due to her long working hours and cost constraints. The solution to Lisa's challenge is expanding Optum's current mobile clinics and existing partnerships. So these mobile clinics will be sponsored by corporate employers such as Walmart and other big box employers, and deployed directly on site. Employers are thus improving the health of their workforce, increasing productivity, and lowering overall insurance costs. By opening up the service to community members, they can also further boost their CSR efforts. These mobile clinics will provide scalable primary and preventative health care, addressing accessibility and affordability issues of low-income communities. These mobile clinics will be scheduled to visit employers' worksite on a regular basis and for workers and other community members to access. They will operate 6 days a week, 10 hours a day, providing care for approximately 60 patients a day per mobile clinic. They will be staffed with 2 social workers and 2 family nurse practitioners, and they will have 2 sets of staff on rotation. Proactive vehicle maintenance once a month will also ensure continued high-quality service and reliability.
The benefits of this approach solve the challenges of accessibility, affordability, and time constraints that Lisa and the community at large experience. It takes Optum's current approach and reduces its size and capacity for daily operations and deploys the larger and more specialized vehicle for monthly visits that would require referred care otherwise. Optum can adapt the healthcare services provided based on the needs of the community. Mobile clinics result in an average of fewer emergency room visits each year, translating to an average savings of a fifth of the cost of care. Mobile clinics also provide cost-effective prevention services that reduce the amount of care an individual needs over their lifetime. Patients visiting mobile clinics reported feeling more empowered to navigate the broader healthcare system. Also, startup costs are significantly cheaper for mobile clinics than they are for brick and mortar clinics. These mobile clinics provide high quality care that is flexible, local, and accessible. Some of the risks associated with this model are related to challenges finding culturally competent employees, especially considering the high attrition in this space due to high stress and compassion fatigue. There's also fragmentation from the broader healthcare system and referrals. In order to mitigate these risks, it's important to have strong resiliency training, mental health support, and manageable schedules for the employees, and build strong relationships and systems to connect patients with other services. Based on our projections and corporate sponsors, we project around $2 million in revenue in the first year. In the third year, approximately $11 million of revenue, and in the fifth year, nearly $17 million in revenue. In order to achieve this, Optum can implement the timeline of, in the first year, having one mobile clinic serving approximately 17,000 community members. In the third year, having 5 mobile clinics serving 86,000 community members. And in the fifth year, having 10 mobile clinics serving about 172,000 community members. We recommend entering in the market in Lisa's state of Mississippi. Mississippi has the highest healthcare gap in the United States, has a low minimum wage, and a high percentage of hourly workers. There are nearly 500,000 low-income patients in Mississippi alone. To successfully achieve this, it requires branding, outreach, and strong community relationship building. In order to achieve this model at scale, we recommend increasing the number of mobile clinics across the United States, especially in states similar to Mississippi, such as West Virginia and Oklahoma. It also would be maximizing current partnerships and corporate sponsors and expanding it into other existing markets that Optum operates in, such as India and Brazil. This corporate sponsored mobile clinic can provide quality care to communities like Lisa's across the globe. Thank you.
So who would you sell it to? Who's going to pay for it?
Yes.
You want to answer that?
Sure. So, considering that you have a burgeoning partnership with Walmart, this was our target primary consumer, based on an estimated daily sponsorship rate of 8,500. But this can also be expanded to Target, to McDonald's, anywhere there's a strip mall in the country. We can find a partner or conglomerate of partners to sponsor us.
And you're targeting Medicaid, Medicare, mostly members?
So that's something we had discussed, and we'd be open to feedback on that because, acknowledging that this does, at least the way we've presented it, of it serving the community that is employed by, say, Walmart, but we want to have access to the broader community as well. And we don't know if that would be included in this sponsorship, if people outside of the community pay a sliding scale, just because we are targeting low-income communities. And one reason why we want to have a social worker on hand is that a lot of times low-income communities don't know what they have access to. And so it could give them the opportunity to get on Medicare or Medicaid if that's what they need in order to get more services.
So if Walmart is your sort of sponsor, mobile clinic shows up, parks in the Walmart parking lot. Ideally, the Walmart employees can go and take advantage of that service, but also the community members who are shopping at Walmart anyway. And they're going to pay the,
But then you'll charge them.
You'll charge them, but you won't charge the Walmart employees because it's their corporate that sponsored it, right? Something like that.
Yeah, something like that.
Yeah.
And it also kind of feeds into like why this would be beneficial for Walmart is they do have their health centers and people pay to use those health centers, and they don't have to have all of the costs that are associated with a retail space and just have the mobile clinic. And then, one of the issues with low income communities is that even if you say they have issues, they still don't have the time to go and see a doctor. And so that's why we say reduce the capacity that Optum's currently operating at, and then just send that out monthly or something like that.
Oh, so you're looking at saying to Walmart, you don't have to build your clinic. We'll drive our clinic into the parking lot. So you save on that cost and then send your employees to me.
Right.
Got it.
Where'd you get the 17,000 per van? Is that visits per year or?
On which one?
For the daily
Uh,
operations
yeah.
you're referring to. So that's based on a partner that some of the team is currently working with that has a mobile vaccination clinic company. Their operations are $17,500 per month.
60 patients a day. That's a lot of patients.
That's a lot of patients. That's taken from an average that we've gotten from mobile health maps, 20 minutes per patient. So obviously some will be more and some will be less. That's where the 10 hours gives us a lot of space, and we're rotating our staff on a 3-day basis. Even though we have longer days, this will allow us to see more patients and prevent burnout.
I would base it on a vaccine model because that's like.
Yeah, this is not based on a vaccination.
Not based on vaccine.
This is based on other mobile health clinics that operate currently in the U.S.
Mm-hmm.
So for example, in Mississippi, there is currently one mobile clinic service operating, but they are very targeted to visiting only one community a day. So they're still very low scale.
But you would partner with a business like a Walmart or somebody and this become an employee benefit, basically.
Employee and community
And
benefit.
Yeah, but one thing that's really nice about this model is that it can be adaptable and scalable, and there are other sources of revenue streams as well. So,
Is there any concern, sort of from a confidentiality, privacy standpoint, just because, like, you are watching all your coworkers go see doctors and vice versa? Like, I don't know, is there any, data on that or anything you've come across about something like that being an inhibitor to uptake?
absolutely. So that is something that is really important to work into this model and to the execution. It is one of the flaws of mobile health clinics. However, it's something that can totally be done, and Optum has the skills and experience to navigate something like that. So the first year would definitely be working out a lot of those kinks.
$4.7 million. That's the number of rural veterans that currently reside in our country, with over 30% of them experiencing PTSD, along with an additional 90% experiencing related and associated comorbidities. But in addition to this, over 60% of rural counties in our country do not have access to proper mental health zones. In fact, these are designated as mental health shortage zones, where veterans are more than 10 to 15 miles away from the nearest mental health specialist and the nearest access to care. But more than just millions of people, the problem always boils down to each individual and one person. In this case, we're talking about Jerry Smith. Jerry Smith is a recent veteran who was diagnosed with PTSD and generalized anxiety disorder. But like Jerry Smith, 27% of all rural veterans live without internet access and access to the advent of telehealth and telemedicine. Similarly, when Jerry goes through a PTSD episode, which is variable entirely on timing and trigger, how does he receive the acute care that he needs in that exact moment? And on a longer-term scale, how does Jerry receive sustained access to individualized care and patient providers that would be able to help him through his PTSD and anxiety? So that's where we come in. We're VetNav. My name is Saket. I'm a neural engineering student.
I'm Hunsi. I'm also a neural engineering student.
I'm Connor. I'm a master's robotics student here at Carnegie Mellon.
And we operate by the philosophy that a veteran's worst wounds might be the ones that you can't see.
So what solutions are currently offered? So if you look at this figure, it's hard to see the lines, but we want to focus on access versus comprehensive. So while there are solutions like crisis hotlines, VA outreach programs, as well as computer-assisted cognitive behavioral therapy, which is very accessible, but they don't really provide a long-term effect. They are very in the moment acute care treatments. There's also socially assisted robotics. So this is an upcoming and emerging field, but also with this, there's a lower access with this one, even though it does be a little more comprehensive, as well as cognitive behavioral therapy with a person, which may be because of distance constraints as well. So we want to focus on something that has high accessibility as well as it's comprehensive. So that's where we come in, VetNav. So with VetNav, we're a very integrative solution. We work without internet dependability, and we provide access to mental health specialists. We're also comprehensive. Oh, I realized it's not on the slide. There we go. It's also comprehensive because we want to focus on long-term PTSD care through computer-based CBT. What we're essentially doing is we're taking all of the solutions you saw on that previous slide and coming together in a very novel way by also allowing this additional feature of being predictive. Adaptive learning basically takes in all of these features that this person is learning in the moment when they're having an episode and basically makes it so that they're having specialized care over a long-term treatment. We're doing this with a social robotic called Robbie. It is a robotic assisted veteran independence. And it also allows biofeedback to provide episodic treatment. And over time, it will learn how to care specific to that patient. So what happens exactly when intervention is needed? So let's say someone is having a PTSD episode. If they had a fitness watch, they might monitor heart rate or a spike, which might be caused by an anxiety. So by doing that, it would be working with our robotic-assisted veteran independence device, Robbie, to then kind of provide tactile stimulation to this person. In this moment, that person who's experiencing a PTSD episode is getting the care they need in the moment because that device is providing tactile stimulation or touch. Oftentimes, PTSD episodes can be really diverse, but it is common that tactile touch can be one of the things that calms them down. In addition, rather than just being a standalone device, we're also working with telehealth specialists, and this would be providing long-term care. So a person who knows this individual going through this PTSD episode would be able to care for them, tell them exactly what they need, try to help them identify what their triggers are. So in addition, this whole thing is an integrated platform, and we'd hope to have more successful patient outcome with it.
So that you know what VetNav is, let's talk about everyone's favorite topic, logistics. So first, we have 3 partnerships that are vital to pulling together VetNav. The first is Optum, our benefactor for today. They will be in charge of using their expertise in data analytics and specifically through the Optum Insight branch to be able to bring together optimizing the community-based outpatient clinics and being able to bring together which clinics actually are servicing which areas. That data analytics expertise that Optum has to be able to effectively allocate resources. And additionally, we have the Veterans Affair. This is a match made in heaven with Optum through their existing communication channels with the Community Care Network. And the Veterans Affair, this is their mission. They have the contacts and they have grants that are able to fund initiatives that help veterans. So we can look to deploy VetNav through their Rural Veteran Health Access Program. We can look to help use their expertise in providing care to veterans and being able to boost the training and also the number of mental health care specialists that are able to provide care to veterans. And additionally, with their current access hotlines and everything, and Optum's ability to provide telehealth, we'll be able to bring these two together and be able to provide a really targeted telehealth system. And lastly, we want to partner with SoftBank Robotics to be able to develop Robbie. We want them to be able to look at the biofeedback integration, and they have existing expertise in social robotics through Now and through Pepper. So they also have IP. So this really will reduce the amount of effort that will be needed to develop Robbie. And if we look at the benefits to everyone involved, the VA will be able to lower costs to provide care to veterans. Right now, if we can effectively allocate resources to mental health specialists, we can reduce the number of mental health specialists that we need. And additionally, they'll learn and be able to get involved with their patients in a much more effective manner by using Optum's ability to optimize which healthcare specialists are actually allocated. Additionally, this, as I said, this is their mission. So this is a great benefit to them. VetNav will be able to directly service their mission statement. And we'll look to SoftBank, or SoftBank Robotics. This will be able to help increase their corporate social responsibility and also help them enter into a $1.7 billion market with rehabilitative robotics. We can also look at Optum. They'll be able to have real-time data collection of how effective this service is, anonymized, of course, and they'll be able to use this data to effectively start to tailor the providing services to these veterans. And lastly, our most important stakeholder, Jerry. Jerry will be able to increase his engagement with mental health care specialists and be able to really provide and start treating his symptoms instead of being afraid of them. He'll be able to, start to really be involved with his mental health and start to take control of his mental health care. And additionally, he'll be independent. He'll get more independence from needing to be near a clinic, from needing to be, have transportation and event that he has an episode during the transportation, that would be catastrophic to say the least. So by having the telehealth care and the Robbie intervention system immediately available to him, this will provide much better outcomes. So lastly, let's talk about how we actually go to market. So in year 1 to 2, we'll have an initial pilot. We'll work with SoftBank Robotics to prototype Robbie. We'll work with the VA Health Clinic to start to set up this infrastructure, and we'll be able to test Robbie's ability to actually work with veterans in kind of trials. Once we have a product to start deploying it, let's deploy it. So we have the training phase where we'll use our contacts with the VA to deploy to rural clinics, and to be able to gather this data, but to find the kinks in the system and be able to actually start making metrics to be able to measure the success of VetNav. And finally, we will be able to work out these kinks. We will provide updates to Robbie and be able to really optimize our distribution channels and work with the VA. Now that we have some initial results, we'll be able to work with other stakeholders, bring them in, and start to really scale up VetNav.
So you're proposing building a robot, essentially, that could detect when a veteran is about to have an episode, and through a tactile experience or intervention, reduce that moment, anxiety, whatever. Is that correct?
So in addition to that, that's correct. We're also looking to provide healthcare, I guess, across the entire continuum of care. So that's why we're integrating the socialized robotics or social robotics with cognitive-based therapy. And at the same time, both the robot and potentially an external fitness watch or heart rate monitor would then communicate with each other to kind of get that biofeedback and vitals that are needed. And that data can then all be used to help inform mental health specialists' kind of conversations with the veteran.
I think it's also important to discuss that we're offloading a lot of expensive features from this robot into the fitness watch. Additionally, these fitness watches, a lot of them already are starting to have involvement in healthcare, and that integration is really valuable because we won't need that really in the robot. The robot will need to communicate with the fitness watch, but the robot itself will be much less expensive to develop because we're actually utilizing the features that already are in the fitness watch.
And then how would you coordinate that, recording that episode and getting that back to the psychiatrist that is treating that veteran?
Yeah, I don't mind taking it. So essentially by using the fitness watch, if we had already created that connection between the fitness watch and then Robbie, we would have to have a way to kind of transport that information. And we're hoping that maybe in part of the infrastructure that we talked about earlier, we'd have like a database that essentially that all the Robbies would be able to be loaded. You'd have obviously a personal database for each person, but essentially that database would work as an offline database. So you can have multiple users on end. We'd set up the telehealth with that database access, and you'd basically be working still with your provider. Would they be able to know essentially in the moment? Probably not, but they would still be able to understand, okay, you had an episode, how was it? Were your symptoms any less? And that's kind of the main goal for this. So it's very much opening a communication between the telehealth as well as the veterans, but then using that technology intermedium. Yeah.
And did you say you're using the VA's existing sort of, mental health, behavioral health services, right? Did I understand that? You're just kind of facilitating the connection to those professionals to start the CBT?
Yeah, that's correct. So I guess going back to the first slide, with 60% of most rural counties being in shortage zones, we're looking to kind of optimize the zoning structure of current VA community-based outpatient clinics and kind of create a more consolidated network, kind of like what CVS did with Minute Clinic, looking at having a doctor per multiple clinics, which all have nurses. So you'd have people on site at each CBOC that would be able to do the minimal integration with Ravi, getting the watch set up, et cetera, and then having mental health specialists designated to a certain zone.
I would think Ravi would definitely be prescribed. I don't think it would just be for anyone, as well as PTSD symptoms are so varied. It would take someone a lot to need even the tactile stimulation for one. The tactile stimulation works a lot instead of jamming a knife into your fake foot that no longer exists for people's phantom limb syndrome. This is a little cleaner way of kind of addressing to give someone that same sense of you're okay. Like what you're imagining is very real. It's real pain, but we want to kind of give it in a little compact way. So yes, it would definitely be prescribed.
Along those lines, it also helps with minimizing costs related to clinical trials, given that we're not trying to make a diagnostic device. It is already provided by a mental health specialist or provider.
You said a couple times there's no internet required, but I'm seeing a bunch of places where it seems like internet's required. If you're going to do a telehealth visit, Rowdy has to upload. So help me understand where the no internet piece comes in.
Sure. So I guess at the minimum, the goal is to first get a solution that addresses acute episodic treatment. So within our first iteration, Ravi would be able to indeed, help a veteran specifically during their episodes. And with the remaining 73% of veterans that do have internet access, we would be able to start telehealth more easily. Over time, we plan to include router and Wi-Fi access within the robot as needed in order to help with that, facilitating that communication. But of course, that's why we have the pilot study during the years 3 to 4 range, so that we can ensure that we're actually addressing proper pathology of PTSD and different symptoms.
Have you identified, I get you probably don't have the spec for this robot yet, but have you identified based on any research, even like the method of interaction? I mean, you mentioned tactile touch being a very important mechanism by which these episodes are relieved, but have you identified any sort of realm of what that looks like or
Yeah.
the effects of those in other studies?
Yeah, so we can compare.
Along those lines, a lot of social robotics has been tested in children with developmental disabilities who often experience seizures or tantrums. Personal experience, I have a brother with special needs, so I've seen a lot of how immense pressure is able to help him calm down and focus, similar to people who experience panic attacks. So in the literature, it's been proven that social robots are viable candidates kind of through haptic feedback and just pure pressure, like imagine hugging a robot in a sense. Through that pure pressure and haptic feedback, you're actually giving enough sensory input for a veteran to help alleviate their flashbacks or outbursts during a PTSD episode.
SoftBank, because this is their IP, they're being able to essentially sell us the robot. They were asking them to be able to fund part of that, since partially this will be this is their product that they're going to be able to sell. Additionally, VA will be able to provide some fundings as well, because this is their mission. This is what they have, grants available to be able to fund this. And yeah, did I answer?
Not the development of the robot, but like once the thing is already built, developed, IP's owned, whatever.
Sure.
On a patient by patient basis, you're sending these patients home with their own personal therapy robot.
Mm-hmm.
Who's paying for that for each patient?
Yeah, so that would be through the VA specific grant programs. Specifically, the one we had mentioned was RVHAP, which specifically focuses on rehabilitation and also retrofitting veterans' homes with rehabilitation assisted capability. So that money, I believe the $2.7 million number comes from fiscal year 2020, where that's how much money they did award, and they awarded $1 million last year similarly. So that money would then come and be used to fund robotics initially, and as we work to bring the costs down, that burden could be placed less on the VA.
So again, getting back to funding the development of it or the actual use of it?
So that would be funding the actual implementation through getting it to a community-based outpatient clinic, then getting it to the veteran's home, whereas development would be done by SoftBank to help modify an existing design.
Yeah, so if you want to
So
speak to
Optum, you had $2 million in there.
We can go back to that slide.
3 million.
Oh, 3 million. Okay, 3 million.
Yeah. Okay, so with Optum, Optum's strength is in the kind of data analysis and as well as the predictive zoning and kind of ensuring that the databases for the veterans' physiological data is anonymized and can also be deployed smoothly, as alongside data storage as well as potential training capability for the for Robbie.
Today, we're going to outline our solution, which is an extension of Optum's OB home care services to select patient populations. We propose the extension of Optum's OB home care services from only high-risk pregnancies to also include low-risk pregnancies that are stratified by socioeconomic status to improve overall outcomes, to build on an existing infrastructure that already exists within Optum. We know that geographic disparities to access to care, in addition to social determinants of health, cause poor outcomes for select patient populations in this country. We've also seen that community-based initiatives have been successful in generating positive ROI, all while increasing access to care and improving overall outcomes. What we're proposing is the extension of their OB home care program using their existing infrastructure to decrease our reliance on high-skilled workers such as nurses, and also to shift the cost burden off of large payers. The data reiterates that low-income women and women of color bear the brunt of the significant costs of care associated with poor outcomes in this country. We also know that these disparities place large cost burden on the system overall, with $50 billion in costs attributed to these disparities each year. The geographic maps at the bottom of the slide show low birth weight and maternal care deserts overlaid over each other. The darker the purple and the darker the pink, the more that these factors are present. You could also see median household income projected with infant mortality rate for Black and white women, as well as percent low birth weight. You could see that the poorest outcomes are associated with the poorest people, but also that Black women have 2 to 3 times higher the infant mortality rate than white women for every single household income level. Clearly, any effective community-based initiatives will need to center on these factors in order to be successful. These 3 initiatives are maternal home-based care programs that have been successful in these realms. They've all demonstrated statistically significant improvements in outcomes such as preterm birth, infant mortality rate, and low birth weight. But in order for these programs to serve as models for our solution, we also have to address their limitations. Namely, these programs are far too reliant on highly skilled workers such as nurses, which we know from the COVID-19 pandemic are subject to labor shortages and are also very expensive to retain and train. These programs are subject to word of mouth referrals and also are completely dependent on state and local government funding, which makes it difficult to scale to a regional or even to a national level. My colleague Megan is now going to go into the specifics of our solution.
Thank you, Zach. So currently, Optum offers OB home visiting programs as a care management model, primarily for high-risk pregnancies, leveraging clinical nurses to provide some clinical care at the home, as well as doing some educational and telephonic support. This program does provide sort of that base infrastructure and some tested methodologies with home visiting. However, as we've discussed, we're looking at disparities in low-income women, low socioeconomic, particularly how we address shortages in clinical workers and also the cost associated with that. So we're looking at expanding this program, just kind of using that infrastructure, but employing maternal community health workers. So these are non-highly skilled healthcare providers that would go through about a 3-month intensive training program to deliver perinatal education and do some like very basic health checks to increase education, provide guidance, and initiate referrals when needed. The main goal here is to also help get that longitudinal relationship with someone who's similar to you,
who a similar demographic and help to erode some of those barriers to trust in the healthcare system and reduce some of that effective systemic racism by giving someone a trusted partner throughout their pregnancy. Additionally, by looking at this as sort of a product expansion, we're able to leverage some of Optum's existing tools within this one product, looking at a 24/7 nurse support line that a member could be directed to call, and coordination of care capabilities. Now, looking at the broader suite of Optum products, this allows this program to be further enhanced and refined to increase the effect. So Impact Pro, essentially identification and stratification tool, can be modified to help identify the pregnant individuals who are most likely to benefit from this program. Zach talked about some of the factors earlier related to income, minority population, zip codes based on geographic care disparities, et cetera. Of course, then segmenting out high-risk OB that could be covered elsewhere and are not appropriate for someone with a lower level of education to be working with. Additional maternity support care management programs have sort of a fundamental education program that could be scaled down and leveraged by the maternal community health workers. And then provider assets, as well as care management staff that have developed these programs, are already well positioned to deliver that training that would be needed to upskill these community health workers, and where possible, act as part of the care continuum if the member is seen an Optum care provider. And the relationship with United Healthcare provides an ideal insurance partner for the initial pilots, specifically in terms of markets where they're doing managed Medicaid, which we know is a very high factor, as demonstrated in our graph earlier. So now let's kind of talk a little bit about the program and how it works. So maternal community health workers can be trained to deliver a standardized curriculum to mothers during pregnancy in their first year postpartum. So how this works, it centers on home visits to create that longitudinal trusted relation and erode some of those barriers to trust. They would be bi-monthly in the first year, they would be bi-monthly in the pregnancy and first 3 months of the child's life, centering on sort of education, basic health checks, things like blood pressure to screen for hypertension, blood sugar for gestational diabetes, doing some postpartum tradition and basic child caring skills, and then looking at that kind of 3 to 12 month tapering off to 1 visit per month, doing more of developmental milestones, basic education, and kind of pulling them out of the program. The curriculum, as we mentioned, would do some of those basic clinical checks, but mainly focus on education to meet the needs of the population. Things like basic nutrition, how to mix formula, benefits of breastfeeding, a little bit on childproofing. You know, the benefit of being in someone's home is seeing what they're working with and recognizing where there may be gaps and pointing some simple things out like, oh, you haven't done this, your crib is here, let's talk about that, that require a little less education on the part of a community health worker, but may be a barrier that someone doesn't know who's in one of these populations. And then when we think about recruiting the maternal community health workers, they need to come from demographic communities in which they're serving to have the maximal impact on helping to erode some of those barriers to trust and reducing the impacts of racism. Now, this is sort of a double play with equity. Maternal community health workers could be recruited from traditionally overlooked populations, thereby providing a path to a well-paying job for those communities and eroding some barriers to equity in terms of the cycle of poverty and giving paths to jobs there. We can also look at kind of career laddering people as the program goes on to provide growth opportunities. Now, our program is estimated to cost roughly $3,500 per patient, plus some additional startup costs. Now, this comes down to about $170 monthly. This includes the initial training cost reduction, which is higher than your standard care management program. But this is a home visiting program. We have costs to get people to the home. And as you kind of train and build that workforce capacity and need to just move to continuing education, you'll see that training cost and overall cost decrease. The benefit of a lower startup cost and building off an existing product infrastructure is that you get a lower barrier to starting up the program, looking at kind of modifying existing program materials and existing algorithms. And then we anticipate around a 2-to-1 ROI, although since it's a new model, it may change. We're not quite sure. We're seeing the home visiting programs with nurses averaging 4 to 5. We recognize we're using much lower skilled workers, so we're going to see a reduction there. But traditionally, care management programs are hitting the 2-to-1 ROI mark. And so that's what we're anticipating is likely going to happen here, but of course, you can't be quite sure. Now, we developed a go-to-market plan that leverages United Healthcare's and Optum's capabilities to train the maternal community health workers, pilot and refine the program, and then bring the program to market. Of course, identifying the target health plans, leveraging relationships that already exist and where you're selling these products already This could be bundled in as an add-on, but we're going to start with a pilot to learn and to refine our program, ideally with United Healthcare in a market where there's managed Medicaid, where we can target the population we want, where we have a high presence and can kind of get a lot of things working in our favor to learn about it. Then we're going to identify them through programs such as Insight Pro, doing that identification and stratification to identify the women who we think will benefit most, have the maternal community health workers reach out to them to encourage them to enroll in the program, recognizing, of course, like any program, not everyone will enroll, and then establishing KPIs and monitoring progress to measure efficacy and continuously improve the program. On the longer scale, we would want to then expand the availability as a product you would go to market with across all insurers, maximizing reach across the country. Now, this go-to-market plan ties in with our timeline here. We give some time for ramp up in terms of developing the training, doing that recruitment that you'll need in the pilot market and preparing to launch, going live with an initial pilot in years 2 to 3, doing an internal cycle of lessons learned, expanding to additional pilot cities, and then looking at expanding as a product no later than year 5 to the broader market. Of course, one of the limiting factors here is the human capital in terms of hiring folks, but we think that there could be sort of a continuous cycle of people coming in. So now I want you to meet Monica. So Monica is a Hispanic low-income mother with no past medical history. She wouldn't flag as a high-risk pregnancy. She lives in a maternal care desert, and her 2-week-old son was born in a hospital without complications. She's been enrolled and has had a maternal community health worker visiting her bi-monthly during her pregnancy, and she notices her son's face and upper chest starting to appear yellow. He's jaundiced. So she knows from her maternal community health worker, oh, maybe this is something I should watch, and reaches out. The nurses confirm a little concern, connects her to Optum's 24/7 nurse line, reminds her, this is something maybe we should go to the ER for. So she goes, the jaundice is treated before there's any resulting brain damage, and our total cost here projected is much lower than what could happen if she doesn't have that kind of trusted resource to reach out to and hasn't been taught about those red flags. And this journey, without the prenatal programming, we're seeing that she doesn't kind of take action. She's not quite sure what to do. Her son becomes unresponsive. She ends up in the ER. But the jaundice is not treated before her son suffers permanent brain damage. So not only are you kind of having the higher total cost of the acute care, you're getting longer term costs to treat that permanent brain damage. You're also seeing long-term effects on Monica's family and her way of life and how she does life with a now long-term disabled son. So we believe that expanding the existing home visiting program and segmenting out a portion to look at low-risk women using maternal community health workers will help to lower costs for payers and for patients and build on existing Optum health infrastructure to improve health equity at a broader scale and help to close some of these gaps and disparities that we're seeing in maternal health care in the U.S.
The $3,500 per patient is pretty high.
Yeah.
And you talk about a 2-to-1 ROI, but I assume you're comparing that to high-risk care management because there's not a lot of low-risk care management to compare to. But you're talking here about low-risk care management. So how are you going to have the same ROI because the patient costs are going to be less?
Yeah, great question. So yes, the 2-to-1 ROI is seen in the high-risk OB programs. McKinsey also conducted a study looking at sort of broader care management programs, everything from chronic disease care management, which still does typically hit the kind of higher echelon of patients, and other care management programming that is seeing that 2-to-1 ROI. We went with it because programs like Nurse Family Partnership are seeing over a 5-to-1 ROI, doing a very similar type programming. They are using a nurse. We know that's not feasible, not using someone as skilled as a nurse. And so our best estimate was to significantly discount that and then look at what we're seeing for care management programs across the country. We do know that social determinants of health and barriers are attributable to 80% of health outcomes. And a lot of the things related to infant and maternal mortality or morbidity are largely preventable and heavily related to education and access to care, which we believe even at that low risk level, we can start to get at. Also, having someone who's trained who can recognize like, oh, this feels like we're getting to something kind of beyond my scope. Given the broader suite of Optum care management products and those high-risk products, they can initiate that referral when it gets there, potentially before a model, an algorithm which is using claims data, which can be delayed, flags that as, oh, we have maybe a high-risk OB patient it goes into a care manager's queue that takes them a while to work and get to. They can make it directly and get them into a higher level of care management if needed and capture some cost benefit there.
So in your model, are the visiting nurses or individuals, are they employees?
Yes. So that is the model that we've modeled. We think kind of pulling them into the Optum network has advantages in terms of employment and doing that training. If you were to try to outsource it, Optum would incur additional cost of outsourcing. And you have a lot of let me flip back this way, things to leverage in terms of training and doing that curriculum development. People who are already doing kind of care management those nurses can help be part of teaching. And then, as a company as large as Optum, you deliver training programs to your employees all the time. You know how to train people well and can scale up that programming. Having them in the Optum network also kind of, at least in what I've seen, you can give them better access to different data. You have a few less privacy concerns when they're looking at patient charts and what they're seeing in the care management program that can allow for better connectivity than if you were to use someone not licensed through your own system.
I know community health workers has been around for a while. I'm just curious if this is an untapped market using community health workers in a new, just specifically focus on the whole perinatal and maternal care aspect, because I haven't heard of that before, but I know community health workers have been around for 10 years or so in existing programs and developmental features like pen medicine with the impact model. So I'm just curious if it's just brand new.
Yeah, so we haven't seen them, at least not in the research that we've done, being used specifically here, where you're training someone more intensely in a more niche space. But yes, they started, community health workers have a long history in public health, starting out a long time ago. They sort of phased out in the US. We saw they're used internationally now. As we're seeing sort of healthcare trending back towards the block with like startups like City Block and other people, we are seeing the resurgence of community health workers, but we haven't seen them particularly here and targeted in one area where they can kind of gain expertise, continue to gain it even through continuing education in the program, and delve into one thing like this.
Yeah, and just to echo Megan's point, we didn't see anything in literature looking at it, and the curriculum we derived is completely unique based off our individual experience, both in the healthcare equity space, as medical students and as dietitians. So it's kind of a uniquely crafted, but also Optum would definitely kind of gather their physicians or their dietitians to mold for that curriculum.
Yeah, the curriculum also pulls off of what we're seeing the other nurse home visiting programs do.
Good evening, I guess. My name is Anushika. This is Mike, and we're representing Team Stepper Up. And today we're going to talk to you about our solution Rehab, which is a gamified AI-driven rehabilitation product that's specifically focused towards helping low-income minoritized communities with their physical therapy needs post-surgery.
We'll first talk about an opportunity gap, which Rehab can enter and Optum can help support, and then introduce you to Anita, a person who recently broke her wrist and could benefit from the solution that Rehab has to offer. We'll next take you through a patient journey and provider journey through our mobile application and similar provider-facing dashboard. And before we open it up to questions, we'll take a quick look at the market sizing and valuations.
So racial disparities are pretty heavily embedded in the US healthcare system, but in the last decade or so, there have been initiatives that have been targeted towards collecting more racial and ethnic data in medical practices so we can identify discrepancies that can help us bridge the gap in fundamental care. But when we were exploring the space, we were surprised to find that a lot of these initiatives have strong success in creating parity in the initial treatment, but there is little change in the outcome differences. So there is a black box in the middle, which is the area that we're focusing on, that we wanted to investigate through this case. Now, primarily low-income minoritized populations are less likely to receive rehabilitation referrals after discharge, and they're less likely to be seen for injury-related outpatient visits. And so this can stem from provider bias. It can stem from a rehabilitation program that doesn't work for them. And there might be a belief on the provider side that because these patients are underinsured or lack insurance, they might not be able to afford physical therapy. Racial discrepancies contribute to worse long-term trauma outcomes, and research has found that low-income minoritized populations are less likely to have a long-term care strategy for pain management. So they rely heavily on ED services for their routine care needs. This is a very heavy burden on the medical healthcare system right now. So we're focused on high quality care, which is high patient-provider engagement with improved outcomes. We're focused on low-income minoritized populations, so we're looking at Black and Hispanic individuals and families that are underinsured or may not have the income to support out-of-pocket expenses for physical therapy. And we're focused on a positive and comfortable patient experience. So we're looking at high patient satisfaction with no perception of bias. For this, we specifically focused on a very common traumatic injury that requires physical therapy, which is wrist fractures. Wrist fractures are very common, they're very treatable, but they also have a connection towards long-term pain and long-term disability. So there's about 720,000 wrist fractures that happen in the US each year. Of them, about 575,000 go without any rehab. This is a huge missed opportunity for us. And by filling this gap with our solution, we're hoping that we can target about $250 million annually in benefit to patients and to Optum in terms of savings. So meet Anita. Anita is a Black woman, middle-aged Black woman who works 2 part-time jobs to support her family. Both of her jobs did not provide her any kind of insurance. During one of her shifts at work recently, she broke her wrist. She's had pins put in it. And she's currently looking for a physical therapy program that will fit her requirements. So she wants to connect with a therapist who she can trust and who she can forge a relationship with as she tries to get back to her normal life.
So Anita is first introduced to rehab through a CIEL, Clinical Informatics Education Lead, which is typically present at the facility she would have received surgery. There, the CIEL will take her through the registration process, as well as describe the purpose of a rehabilitation plan. Every day, rehab then prompts Anita to answer a single, simple, outcome-oriented question to track her pain over time. In addition to these questions, Anita will also complete gamified exercises, pulled from a wide library of exercises activating her wrist, as well as coaching tutorials on how to perform these exercises. This rehabilitation plan will then take her results of performance and adjust the games that she's playing, as well as the mechanics within, in order to support a long-term care strategy. Now, whenever Anita reports an elevated pain level, rehab would also prompt her to connect or visit a physician within her area, hopefully managing her pain strategy actively and keeping her out of the ER. Importantly, the matching process occurs around Anita's demographics, geography, and availability, hopefully building trust as well as feasibility within Anita's lifestyle. Now, all of this would be incomplete without similarly strong provider-facing tools. This rehab system, because it's actively able to track Anita's performance over time, is able to provide recommendations towards the physician on needed next steps in her recovery, whether that be, again, additional pain management tools, more active rehabilitation exercises at home or with a physiotherapist directly, as well as removing some of the bias which might be appearing in the rehabilitation process. Importantly, through rehab's responsive and flexible rehabilitation process, as well as higher compliance we're expecting through gamified exercises, Anita is able to return back to work safer, stronger, and sooner. Now, partnering with Optum provides a unique opportunity within rehab's platform across Optum's entire business line. Within the first year, we're expecting about $140 million, shortly after launch, we're expecting $140 million in savings potential towards all health payers, and United Healthcare included in that. And as we expect to scale by about mid-2025, expanding to new opportunities such as wound care, total joint replacement, and stroke, provides integration of data across the full patient recovery journey to be brought into some of the insights which Optum Insights recommends to facilities supporting cost mitigation strategies, as well as outcome results. Oops. We expect rehab to be able to provide the equivalent of 2 physiotherapy sessions per patient. What this results in is about $140 million value extension being offered to patients. Now, this is not something which is directly realized to Optum, as about 3/4 of which is directed to patients who currently don't receive any physiotherapy. However, we've already noticed that that population is specifically benefiting as well minoritized populations. The real cost savings come out through the reduction in the reintervention rate coming from reduced malunions for people who don't have physiotherapy right now, as well as a reduced volume of emergency department visits related to pain, about 18% of which happen, about 18% of all emergency department visits within 30 days after the surgery.
So to conclude, I want to draw us back to the important features of rehab that make us unique. We have a quick patient check-in and a live provider dashboard, through which we aim to optimize time and flexibility and improve communication between patients and providers to ensure maximum adherence to pain management regimes. Rehab leverages AI to improve patient and provider matching and aims to eliminate bias and optimize equitable outcomes. Most importantly, we would be the only platform supporting small trauma recovery through combined rehabilitation programs and patient recovery tracking. Chronic pain resulting from traumatic injury can be very debilitating, and it can impact a person's ability to live their life fully. With the focus on post-surgery rehabilitation, rehab hopes to help millions of underserved Americans return to their normal lives in a healthier and safer way.
So just to be clear, so this is a telehealth platform that will match physical therapists to an individual, correct? It's not prescribed? It's self directed, or is it prescribed through? You mentioned like post surgery, or so would you be marketing and partnering with providers?
So a couple clarifications, and this is good. The service itself does not directly provide the service of the physiotherapy matching. So it is not a telehealth system. It is directing patients towards a physiotherapy system. However, what it is providing is basically a gamified exercise, something you can take home, do on your own, fit into your own time schedule, which is taking the place in between those physiotherapy visits that otherwise would not be happening. Similarly, however, what you talk about in terms of the referral, yes, that is being referred across through the provider itself. And whether that be directly at the system or, again, following a reimbursement tag, a flag then to download an app, go through the system, again, filling that gap of rehabilitation that would otherwise not be offered.
Wait, so what's the route to the PT? Is it through the provider referring, or is it through this surfacing one that they should go to based on their insurance, and then the provider refers?
So currently, the gap exists where providers are to recommend people cross towards physiotherapists. The unfortunate thing is that just doesn't happen frequently enough, and specifically that doesn't happen for minoritized populations. Again, talking about that bias that we were discussing. So importantly, what this app does is it takes that referral process and says, hey, here's a physiotherapist which would match your needs, your proximity, your location, and then you are entirely correct. The referral incentive does work across between the physicians that way. However, the app itself is taking that referral process, again, finding that appropriate match.
But the provider still has to then get the patient to use this.
That is correct.
So why would they, if they're not doing a referral to a provider because of the biases you're talking about, what would make them give you this because of those same biases?
So, and again, these are really good questions. The first bias which appears is we don't believe you're insured. We don't believe that if I suggest you towards a physiotherapist, you will show up, you'll be able to pay for it. And this is a couple noted literature items that I know there were references down below, all of which were directing towards those two primary biases, again, directly related towards insurability. Now, the intent with this app alone, again, is it is able to fill some of that gap. The fact that we anticipate it being able to support that rehabilitation process as a half step even is better than nothing. With no cost towards the patient for downloading the app and being able to play some games, get that wrist activity moving. However, when it is needed in those instances, then that referral is then able to be made.
And then you had that chart that showed, how much Optum was going to save, and then how much of that savings would be sort of, realized with underserved populations. So it sounds like what we were just talking about here, that's that 112 million, right? Like those are the patients that right now aren't even being prescribed any physical therapy. We're going to try to, hook them on this app as a pathway in, and there's savings there. Like what's going on with all this other stuff? So these are, on the direct side, these are patients being treated in the Optum, United Healthcare environment somewhere, and they're also using your app, or where do these people come into play?
So everyone who's listed here is across the entire healthcare system. And just to jump across towards some of the data that we have on the side, what we're looking at here is, again, the total number of patients and the value we'd be realizing across some of these potential volumes. Importantly, emergency department visits, as well as reintervention risks. You're completely right. This is not reduced in order to take a look at United Healthcare's penetration, right? These are cost savings, which we mentioned. These are not to necessarily be realized within, let's say, the traditional sense. However, again, we talked about some of the scaling issue being able to be brought across other treatment areas, right? That is really the revenue opportunity for Optum to jump in on this. There were indications which we talked about of heavy investment going in towards facilities, talking about this racial equality score, where this equity data and new metrics were being brought into place. Importantly, that's where this rehab app steps in when we talk about scaling. This is something Optum Insights is able to own, track a patient's journey after any intervention, and convert that over towards a metric for facility-based racial equality. Again, ultimately, rehab is a first step into this business for Optum to then convert it over towards a data system, while still realizing revenue gains or cost savings along the way.